Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by Abbvie, Apellis, Janssen, MeriaGTx, Novartis and Roche. Thank you for watching. We hope you enjoy this webinar and share your thoughts with us in the comment section below.
Welcome, Dr. Gooi. So happy to have you here. So just as a little introduction, Dr. Gooi is the glaucoma subsection lead and fellowship director, as well as an assistant professor at the University of Calgary. And he specializes in the surgical management of glaucoma, complex cataract, and anterior segment reconstruction. And we're going to talk a little bit more about surgical management of glaucoma later in this talk. Dr. Gooi, as well as his sort of official roles, is very enthusiastically involved in medical education and innovation, and he's a Western Canadian leader in novel glaucoma surgeries. So I am going to sort of jump right into some questions. As Morgan said, we do already have a lot of questions coming in. I can see some already falling into the chat there. So we'll try to keep this sort of formal section maybe a little bit shorter if we can, to leave a lot of time for audience questions as we go through it. So just a sort of level set so everybody's on the same page here, because we have some viewers who I know probably know the topic really well, but some who might be a little bit more new to the topic of glaucoma. So I was wondering if you could just explain a little bit more about what is glaucoma and how does it cause vision loss?
Absolutely. So glaucoma, it's a disease of the optic nerve. Now, the optic nerve, it's a wire that basically sends information from the eye to the brain. And it's a very important wire, and basically there's quite a few different forms of glaucoma, but the overlying theme is that it's felt that for whatever reason, pressure damages the optic nerve. So, and many people feel that it damages the blood supply, and as a result of that, if that optic nerve or if the wire that connects sends information from the eye to the brain doesn't function, that's how you get vision loss. That's how you go blind. So even though the eye itself is healthy, if it can't transmit the information properly, unfortunately the patient can't see anything.
And so you mentioned that sort of the pressure can cause damage to this optic nerve. So is it it's always pressure largely? That's generally the main cause as far as
Yeah, as far as we know, and pretty much 99% of our treatments for glaucoma all have to do with pressure. And glaucoma surgeons, a nice way to think about it is we're basically specialized plumbers. So the eye's the kitchen sink, there's a tap, and then there's a drain. And basically, most of the time, the problem is there's not enough drainage. So you get an imbalance, and a result of that, you get a buildup of the aqueous humor. That's a specialized fluid in the eye that's normally there to provide nourishment. But unfortunately, if there's too much of it, you get pressure, and that high intraocular pressure damages the nerve and leads to blindness.
That's actually a really great segue, talking about some of the common treatments. So you mentioned most of them are trying to reduce pressure, but what are the different types of treatments that somebody might get?
Yeah, so most patients, will receive a combination of drops, laser, and some patients will receive surgery. And all of those treatments, to some degree or another, they either turn down the tap in the eye or they increase drainage. And when it comes to drainage, you can either enhance the eye's natural drainage system or you can make a brand new drain.
So in terms of, say, medications versus surgery, how are medications lowering the pressure?
Yeah, so that's a great question. There's about 4, now 5, and potentially 6 different classes of medication, and some of them work on the ciliary body. That's the tap in the eye that produces the aqueous humor, and others enhance the drainage. So they can either enhance the drainage through the conventional outflow pathway, so that's through the trabecular meshwork, so that's the way it normally drains, or the secondary pathway is known as the uveoscleral drainage pathway. And the cool thing is this aqueous fluid, it eventually drains back into our veins and becomes part of our blood, our circulatory system. So
that's I really like that analogy of the drain and the tap. So you can either have sort of too much fluid produced, not enough drainage, maybe a combination of both. So you've talked a little bit about how the medications can impact this drainage process. How about surgeries? What are sort of traditional surgeries doing?
Yeah, so when it comes to surgery, usually that's more a matter of enhancing drainage. And basically you can either, again, enhance the eye's natural drainage system, or so that'd be like snaking the drain, if you think about plumbing, or you can make a new drain. So you can say, you know what, the drain's really clogged up, I'm going to make a new, lay some pipe from my kitchen sink into the backyard. And that's basically that. When you make a new drain, that is the realm of glaucoma filtering surgery, where we're draining fluid from the inside of the eye to, another compartment. Now, they each have their own unique challenges, and we'll get into that, I'm sure, the next bit. So
just in terms of, I know a lot of patients who use glaucoma drops. My mom has glaucoma. She's on drops and has been for many years. About what percentage of patients, roughly, do you think would sort of progress enough that they might need surgery or laser?
Yeah, that's a really good question, and it's evolved over time. So, and this is great that we're talking about MIGS, or micro-invasive glaucoma surgery. Usually for the traditional glaucoma surgeries, it's a small percentage of glaucoma patients. It's probably less than 15 to around 15% of them. Now, however, there's more recently in the last, well, I guess it's not that recent anymore, but within the last 5 to 10 years, something called micro-invasive glaucoma surgery. So it's supposed to be, safer, hopefully, somewhat efficacious, and often done in conjunction with cataract surgery. So pretty much most people, will get cataracts at some point of time in their life. So if someone is a glaucoma patient, I think there's the likelihood that at some point they'll have, some sort of MIGS procedure in conjunction with their cataract surgery is pretty high, so it's probably, 40 or 50%, and depending on which practice you're looking at, sometimes it's maybe even higher, maybe it's 70%.
Okay, and that's an interesting question. I'm going to sort of go back to that afterwards, but let's talk a little bit more about MIGS. You mentioned a bit about what they are. Can you tell us about how they're sort of maybe different than a traditional surgery?
Yeah. So basically, I think the traditional glaucoma surgery, unfortunately, doesn't have the greatest batting average. It's about, in the best case series, 70% successful. They can have a lot of complications from either draining too much fluid or too little fluid. And part of it is that they tend to be relatively larger surgeries. So you're dissecting a lot of tissue. And when you're operating on a lot of tissue, basically, surgery is controlled trauma. So you're causing a lot of trauma, causes a lot of inflammation, and that can impair the results. So how kind of MIGS, well, there's a number of reasons how it came about, but I think people were looking for procedures where they had an improved safety profile, they'd still be somewhat efficacious, and there'd be less disruption of the anatomy. Just because the challenge with traditional glaucoma surgeries is that there's basically a million different ways to skin a cat when it comes to traditional glaucoma surgeries. So you get a lot of variation in technique, and you also have, for the spaces that you're working with, there's a lot of variation in the patient anatomy. So there's when you're in that situation, you can get results that are very different from patient to patient, versus, let's say, modern day cataract surgery, where there's a high degree of precision because it's a very similar anatomy from patient to patient. It's a very similar procedure from patient to patient. And that's why with modern day phacoemulsification, you get such great results. So I think the impetus was sort of to bring that sort of philosophy and that approach to glaucoma surgery. And now MIGS, there's a whole the different options in terms of MIGS have really ballooned over time. Probably the first step is to think whether it is some type of MIGS that enhances the conventional or the natural outflow pathways, or is it making a new drain? So because the ones that enhance the natural outflow pathway, it's a bit more similar to cataract surgery because we have a much greater degree of precision and consistency in terms of knowing where we are in terms of anatomy, and also understanding the physiology a little bit better.
Okay, so that was a really great overview of MIGS. And so there are different types. And
Yep.
is it sort of similar to, like you're talking about, sort of the traditional surgery where there are very many different types of MIGS, or are they more of a handful that somebody might be introduced to?
Yeah, I'd say probably. I mean, it. The interesting thing with the MIGS is, for the most part, all of them are now regulated devices. You know, so they have to get, you know, Health Canada approval, FDA approval. So, and the interesting thing is that there's quite a bit of heterogeneity in terms of geographically, even within Canada, where certain provinces have a handful of devices approved, and that might not necessarily overlap with, you know, the devices that are approved in other provinces. Probably right now, you know, for most glaucoma surgeons in Canada, they would have about a handful of different MIGS options that they could offer patients, you know, at most, you know, realistically, probably, you know, probably 3 to 5, you know, that they'd offer.
Okay. And so when do you think somebody would be offered MIGS, or when would you offer a MIGS to one of your patients?
Yeah, so I think probably, you know, yeah, you know, for glaucoma surgical planning, it's kind of like a combination of chess and real estate, and I'll explain how those, you know, two seemingly dissimilar, you know, subjects kind of intersect in glaucoma. I wish that our surgical procedures lasted forever, but unfortunately they don't. You know, I think it's reasonable to get 5 years out of a procedure is quite good. You know, even many procedures only last 1 to 2 years. Occasionally we can get procedures that last 20 years, but that's kind of like, you know, hitting a home run or a hole in one. So the general thinking is to do a stepwise approach where you start with a less invasive procedure, try to get as much mileage out of that, and then move on to a slightly more invasive procedure, kind of in a stepwise fashion. Now, in some situations, if patients have a suboptimal result, you know, after the initial procedures, you have to escalate therapy quite quickly. But for the most part, you know, we're able to start with a less invasive option. So there's kind of two situations where glaucoma patients would run into, you know, requiring a MIGS surgery, and every surgeon's very different. You know, this is, at least in my practice, fortunately, the vast majority of patients are, you know, under control with their drops and lasers. And since glaucoma generally affects individuals later in life, you know, in their, you know, 50s, 60s, 70s, and cataracts are usually ready for surgery kind of in their 60s, 70s, and 80s, there's a pretty good kind of intersection of when you have a patient who's otherwise has stable glaucoma, but their cataracts are now ready, ready to be taken out. And if they're on quite a number of drops, let's say, 3 or 4 different classes of drops, then we can make a case that at the same time of cataract surgery, since we're there, we might consider doing a micro-invasive glaucoma surgery just to reduce their drop medication burden, and improve their quality of life. So that's probably the vast majority, like I'd say over 70% of how, glaucoma patients would encounter glaucoma surgery. The other situation would be, unfortunately, sometimes for some people, their glaucoma decompensates. So even though they've previously been pretty good on drops, suddenly the drops stop working, and then the pressure goes up. So then we have to do something soon. In those situations, depending on how high the pressure is, they probably need a surgical intervention. If it's moderately elevated, then there's certain surgical micro-invasive glaucoma surgical approaches that could be used. Sometimes if it's extremely highly elevated, then we have to resort to a more traditional glaucoma surgical approach, just because we want a higher chance of success in lowering the pressure.
So to me, the way you're describing it, it really sounds like a lot of these treatments are on a spectrum. So
yeah, totally.
Yeah. So like we talk about MIGS as being sort of this category, but sort of on a spectrum of surgery.
Oh yes, absolutely, absolutely. Like even, I'm so glad you brought that up. Like even within the category of MIGS, there are, less invasive, MIGS, and then kind of more invasive, more effective MIGS. And for the most part, usually it's a trade-off. So if you're getting, if we're looking at a procedure that's really, really, really safe, then the efficacy, also tends to go down. Not always, but that's usually the case. And probably within, I think within the spectrum, there's the Schlemm's canal procedures and devices. Interestingly, those are generally considered, the safest. And in certain patient populations, they can actually be very effective, even at taking on really high pressures, for certain procedures of those. And there are, MIGS that are subconjunctival filtering procedures that some people are comfortable taking on pretty high pressures with. So it really, it's interesting because glaucoma, it's one of those, on one hand, it's one of those big data specialties because it's it's a relatively common disease. So we can actually get pretty big numbers when you look at studies. But when it boils down to it, you have to take a really personalized approach to figure out what's the next best step for the patient right in front of you. Because some patients, they have a really high pressure, and it's just because their outflow has been, compromised so much. So all you need to, and all you need to do is increase the outflow just by a little bit, and you actually get a really, really good pressure reduction. So, I mean, a good example is sometimes patients in their 80s and 90s that we have to operate on, just because they have multiple comorbidities. Often at that time, if sometimes just naturally the ciliary body doesn't produce as much fluid, but their drain is really clogged up, so their pressure is quite high. So, but in that situation, doing something like Schlemm's canal MIGS, like GAT, can actually be really, really effective, and it safely brings down their pressure.
Yeah, no, it sounds, yeah. So I like the idea of that personalized treatment. I think that has come through in what you're talking about it. So, yeah. So when you're talking to your patients, do you sort of discuss any sort of concerns or drawbacks with MIGS or with other surgery that they might want to consider?
Yeah, I think probably, from a patient's point of view, I think it's important. Probably one of the most important things is to, let our surgeons know whether they're on any blood thinners or anticoagulants, because that can affect which surgical approach will go with. Sometimes traditional glaucoma surgeries can be more challenging. There's a higher risk of bleeding, but sometimes you have to do them regardless. And I think probably, just their whether or not they've had previous cataract surgery. A lot of people have, quite a few people haven't. So that might be something to consider as well, just because sometimes if you do for certain glaucoma filtering procedures where you make a new drainage system to another compartment of the eye, if you do cataract surgery afterwards, that actually stirs up inflammation and it can cause the glaucoma surgery to fail. Not universally, but it's a slightly increased risk of that.
Mm-hmm. And sort of drawing back a little bit maybe from MIGS specifically, I was just wondering if there's any sort of questions you've had patients ask you that you're like, oh, that's a really interesting, question, or that other patients might want to ask their doctors. Just around glaucoma treatments in general, not specifically MIGS.
Yeah, I think the lifestyle, lifestyle factors for glaucoma is a big one. So it's interesting. I think the wind instruments seem to be a risk factor. So, so playing the trumpet, playing the tuba,
oh, wow. Okay.
playing the flute, just because anything that is kind of like a valsalva or straining, if it increases the pressure kind of around the chest, that can be a backup of fluid into the eye. I generally recommend them to avoid inversion exercises. So yoga's okay, but we wouldn't want people to do a handstand for, let's say, 5 minutes. And especially there's some people who get inversion tables for whatever exercises. That is not ideal. So avoid inversion tables. One thing for men, like not to wear a tight necktie, so because there's evidence that can increase the eye pressure. So I think, those are the main things. What's interesting is they're going to be looking at a study in nicotinamide. So that's a vitamin B3 supplement, and it's potentially, there's some preliminary work that shows that it might actually be quite helpful in glaucoma. And the cool thing is it is treating glaucoma in a way independent of intraocular pressure. So it's to enhance the, I believe it enhances the function of the mitochondria. So those are like the power cells, the power plants in the cells. So basically it strengthens the health of the optic nerve, or the energy supply to the optic nerve, and maybe that makes it more resilient to pressure fluctuations. So I think that'll be interesting, because it'd be nice, because I mean honestly, glaucoma drops, thankfully they're quite effective for most of our patients with glaucoma, but at the same time you can imagine if there's comorbidities such as, arthritis, dementia, and even just as the glaucoma progresses and vision is affected, it becomes increasingly difficult to, to administer the drops, oneself, unless someone has a designated caregiver, so it's nice to have different options.
We've definitely heard that from patients who some say that depending on also the brand of drop, some of them are very, very hard to squeeze, which I hadn't really considered. So if you have arthritis,
it's tricky just because I mean we're lucky in Canada. We have good access to medication. There's sometimes depending on the supplier for the generics, the appearance of the bottle can change from time to time. So depending on what, like polypharmacy, i.e. being on multiple prescription medications at once, it actually becomes really confusing. So adherence or sticking to the drop regime, we have reasonable evidence that if someone's on one drop a day, it's relatively easy to stick to. But imagine being on, 3 or 4 different bottles, where some of them you take twice a day, some of them you take once a day, some of them you take 3 times a day. And especially if depending on, the supplier, those bottles could actually change in appearance from month to month, so it'd be really, really confusing. So
Absolutely. Yeah,
yeah.
that's even just thinking about it now, and how would you organize your day and
Yeah.
your schedule around the
Yeah.
drops? Yeah. So just to end off, I was wondering if we talked a lot about sort of surgery and MIGS, but just sort of, is there anything sort of on the horizon that you're really excited about? It could be MIGS, it could be other exciting, innovative treatments like stem cells or medications, or what are you sort of looking into the 5 years, 10 years, 15 years that you hope will be coming for glaucoma?
I think that the real exciting thing is, our hopefully we're just scratching the surface on our understanding for glaucoma and pathology, because I think we used to think of the drainage system as a static system like plumbing. Well, it's actually not. It's actually, the drainage system is its own sort of living, breathing organ in of itself. That's why, I mean, we're so thankful, with the to win the Eye on the Cure Inspiration Award, for our because we're actually in the space of developing glaucoma surgical, devices. And I think especially what we were hoping to do with our trabecular excision device is be able to sample the trabecular meshwork, because it's this tiny, amount of tissue that's felt to cause up to 70% of the resistance in about 70% of the glaucoma. Yet we don't really understand what's happening because we don't biopsy it, and we don't biopsy it because we haven't had a really good method of biopsying it. So I think hopefully our trabecular excision device will change that. But so I think the approach to glaucoma surgery and innovation is going to take on a much more molecular approach and a much more precision medicine approach, just because I think the amazing thing would be if we were able to, let's say, let's say somehow biopsy a patient's, drainage system and understand, what would be the ideal treatments for them. It would take out a lot of the guesswork. Even further down the road, the fully realized, solution would be, we biopsy the patient's diseased trabecular meshwork. We use stem cell therapy to regenerate, a line of fully functioning, trabecular meshwork cells. Then we somehow are able to reimplant them into, into the patient to give them the drainage system of a 20-year-old. That would be amazing. So nothing would make me happier than, not having a job anymore, because our glaucoma treatments become so good. Just because I think our job as glaucoma surgeons is, to, do our best to help our patients celebrate life, and I think if, the drops definitely effective and help a lot of people, but, they do have some challenges in terms of, administration, kind of just the pure logistics, and also ocular surface side effects, dryness, red, irritated eyes. So, and I mean, number one, if we can, even prevent one extra person from going blind from glaucoma, that's worth it. I think hopefully we can get there, and then, but hopefully we can start improving quality of life. So then we can, really work on, the celebration aspect of it, and that's not my line. That's from Dr. Spade. He's one of the giants in glaucoma.
I was going to say, well, that's a great line. I'm going to steal it. I love that.
Oh yeah.
Yeah. Helping people celebrate life.
Yeah. So, that's it. So I think hopefully we'll be able to kind of, hopefully by looking at it on, from a molecular perspective, we'll be able to make it a lot more personalized, just because it's, life is not one size fits all. Glaucoma certainly isn't. So, yeah.
Well, thank you, Dr. Gooi. So you're going to stay right there because we're going to have lots of questions from the audience.
Okay, perfect.
I'll give you a moment to sort of catch your breath, grab a drink, and we're going to have my colleague Susan join up to tell you a bit about some upcoming FBC events. But before then, I actually want to put in a little bit of a plug because I'm really excited to introduce that Fighting Blindness Canada has a new podcast that has just launched. So if you enjoy the conversations we're having, please join us to hear about this sort of new way of communicating, where we're featuring interviews with researchers and physicians who focus on the treatment and prevention of eye diseases. And we also go a bit behind the scenes to learn about their research and why they're really passionate about what they do, as well as talking to members of the vision loss community about the impact that vision loss has on them. So sort of a personal look at vision loss and vision research. So this month, we're hoping to have 4 episodes this year, and the first one is a focus on inherited retinal disease. So Morgan has interviewed clinician scientist Dr. Elise Ayon from Sick Kids, as well as talking to a few members of the vision loss community who also have inherited retinal diseases. So you can find the podcast at fightingblindnesscanada.ca/podcast, and you can also find it sort of wherever you find your favorite podcast, on Spotify, on Apple, and it will be on Google shortly. I've actually just queued it up to listen to the episode on my walk home today, so I'm really excited to hear it as well. And we have Susan here. Hi, Susan. I will turn it over to you.
Great. Thanks, Larissa. And hi, Patrick. Dr. Gooi, hi.
How's it going?
Thanks for joining us today. And thank all of you for joining us today too. I'm going to just take a quick minute and talk about some of the exciting things that we have coming up, some of the exciting events that we have that you can participate in and help fundraise so that we can continue to fund some of this exciting research that's happening right now. And one of the fun things that we've got coming up, one of our signature events is our Cycle for Sight event. And together, we're trying to move vision research forward. And this year, it's not just about cycling. We've got in-person events all across the country, and we're also offering walk events in Calgary, cycling and walk events in Newfoundland and Ottawa, and of course, St. John's as well in Newfoundland. And then in Vancouver and Toronto, we're first up on World Bicycle Day on June 3rd, doing a big cycling event right there in those cities. If you're not a cyclist, I encourage you to visit cycleforsight.ca and see all of the different options that you can join and fundraise for us, be a part of our movement, and just join us with Cycle for Sight and do some fundraising for vision research. But up front first, next month, just 1 month away, is one of our other signature events called Comic Vision. This one is taking place in Toronto on May 11th. We are calling this one our cocktail edition. So warm weather, cool cocktails, and lots of fun and laughs with lots of friends gathering together, sharing the hope for vision loss right here in Toronto. That will be taking place at the concert hall right at the corner of Yonge and Davenport. Used to be called the Masonic Temple. Maybe some of you went to a few concerts there back in the day. We are taking it over on Thursday, May 11th for some laughter. We've got a terrific lineup of comedians, and we encourage you also to visit comicvision.ca, grab a ticket, a table, get some friends together. We'll have silent auction, we'll have cocktails, we'll have food stations. We're just going to have some fun, all in support of Fighting Blindness Canada and vision research. Hope to see you there.
Thank you, Susan. Oh, there's Morgan. Oh, we can't hear you, Morgan.
Oh, no.
Oh, there we go. Now you're good.
Now? Okay. It's just trying to get rid of these slides. You can't see the slides anymore, right? They're gone. Okay. All right. So let's dive into some questions. We have lots here. So let's see, where should we start? Let's start here in the Q&A. So our first question is from Mary Jane, and Mary Jane is asking, should you take Vitalux to help with glaucoma, similar as you would to macular degeneration?
Yeah, so Vitalux, unfortunately, I don't think we have the evidence to show that it would be similar to glaucoma, but potentially we are looking, not me, but there's this large study, I believe, in the UK that's looking at nicotinamide. That's the type of vitamin B3 that potentially would be helpful with glaucoma. So I think that's something to, I know some glaucoma specialists are putting some of their patients on nicotinamide, and it's something to potentially speak to your glaucoma specialist about, but it shouldn't be used for people who have kidney or liver issues.
Yeah, so important with vitamins to make sure they don't have interactions with other medications that you're taking, for sure. So we have another question here from Nalita, and she's asking if you're able to speak a little bit about normal tension glaucoma and treatments for this particular form.
Yeah, so you know, normal tension glaucoma, it's a broad category. Basically, it's for people who have typical glaucomatous changes in terms of their testing or their optic nerves, despite having relatively normal pressures. And there's a number of reasons why people could be labeled as quote unquote normal tension glaucoma. One is, and this is not an exhaustive list. Sometimes it depends on the method that we measure the pressure with. There's something called corneal hysteresis, which is it's a biomechanical quality of the tissue. And basically, if patients have low corneal hysteresis, they have low shock absorbers or weak shock absorbers for their eyes. So potentially they can accumulate glaucomatous damage at relatively low pressures. So that's one reason. So sometimes getting a pressure check with something called an ocular response analyzer, that is a device that can measure it. So that's one thing. So in other words, sometimes when we check the pressure with that device, we realize that it seems to be actually higher than some of the other methods of measuring the pressure. So then we're actually undertreating. So then we have to escalate therapy. That can be one option. Another option is there's some patients where our eye pressure, kind of similar to blood pressure, it fluctuates during the day. And so there's peaks and troughs. And unfortunately, some patients peak during or outside of office hours, like in the early morning or in the later in the evening. So they could be coming in for pressure checks and having seemingly really good pressures, but if they're spiking at night, then that would justify an escalation in treatment, whether it's additional drops, laser, or surgery. One option to look at is they are looking at some home eye pressure monitoring applications. One is it's called the home eye care. Another one is the triggerfish, which kind of measures surrogate for eye pressure. So potentially home eye care monitoring is another option. And I think sometimes in glaucoma, we always like to try to keep an open mind. Sometimes there can be non-glaucomatous causes for optic nerve damage and progression. So sometimes that might warrant other investigations, like, you know, an MRI or, you know, things like that. So so those are kind of the big ones. And I think potentially, you know, potentially we also have to look at, you know, non-IOP dependent factors for glaucoma. So simple ones are relatively like home blood pressure monitoring. So if patients, if their blood pressure dips in the evening, then there's not much blood flow going to the optic nerve. And that's a situation where people can accumulate glaucoma damage with relatively low pressures. So sometimes it necessitates taking the blood pressure medication only in the morning and not in the evening, things like that.
So I think in a similar vein, there's a question here from a person who said that they have normal eye pressure, but on an OCT, it showed that they have thinning of their peripheral retina, and the doctor was concerned about glaucoma. So wondering if you could comment on any connection between sort of retina and glaucoma.
Yeah, so probably, you know, they're probably their specialists will, you know, follow them as a, you know, normal tension glaucoma suspect. One connection is myopia and glaucoma. So myopia or nearsightedness, a lot of the time what happens is the eye gets stretched longer and the retina gets thinned out. And the challenging thing is there can be a gray zone where nearsightedness or myopia, patients with nearsightedness and myopia can have an appearance that's very similar to very early glaucoma, but it's not, it's stable, you know. And I think the main thing is just follow up, you know, if it's changes due to nearsightedness, those are generally stable over time. If it's changes due to glaucoma, then those can progress. And of course, you know, monitoring things like pressure. Honestly, sometimes even as glaucoma specialists, we're not quite sure, so we hedge our bets. So we do some treatment, but nothing too aggressive. So we might put the patient on just 1 drop a day, you know, a relatively less invasive drop. So that's kind of the overlap between those.
Thank you. That was really interesting. So I have another question here from Catherine. Again, a lot of people asking about pressure. So she's asking, can you talk about glaucoma when eye pressure is actually low? And is there anything that can be done in that situation?
Yeah, so I think, you know, in that situation, definitely, you know, the lifestyle, you know, factors. So, making sure that the cardiovascular health is good. So sometimes we investigate. So making sure the carotid arteries or the blood supply, you know, to the eyes is good. There's not any carotid artery disease. You know, 24-hour blood pressure monitoring. We'd look into, and just making sure, you know, lifestyle wise that there's no risk factors there. And I think potentially there might be a role for some of the vitamin supplements. Unfortunately, nothing in glaucoma is a silver bullet. I wish it were, but we don't. So it's kind of a gestalt approach.
So I have a couple of questions. You mentioned talking about inversion and wind instrument risks. We have a couple of people here are asking about strength training or weightlifting.
Yeah, that's a great question. You know, so I probably, you know, I'm not a personal trainer, but what we'd recommend is usually weightlifting is okay as long as patients aren't straining too much so they can still talk while they're exerting, you know. So in other words, it would be, so I think doing some strength training is fine, but rather than going, let's say 8 reps at the maximal exertion, going for, let's say 12 or 15 reps, because you can still build strength and muscle mass that way, you know, but so in other words, when they're kind of lifting the weight, they should still be able to, you know, talk and breathe.
So we have a couple questions here about cataract surgery as well. So, for example, Heidi's saying that she had has glaucoma and a year ago had surgery to lower her eye pressure at the same time as cataract surgery, which I think you mentioned. But she still has some difficulty with the lenses. And there was someone who else asked about, trying to find the question here. I think it was something to do with how does MIGS affect if you have a cataract?
Yeah, so it depends on the MIGS, you know. Most of the MIGS procedures are done at the same time as cataract surgery, so it doesn't really affect the procedure too much. It makes the procedure take a little bit longer, but generally speaking, recovery is about the same. Probably the exceptions to that are GAT surgery or any surgery where you do a goniotomy. You can get more bleeding, so sometimes vision takes longer to recover, like a couple of weeks versus just a few days. If there's any of the subconjunctival filtering MIGS procedures like Zen or potentially PreserFlow, if people put it in that category, then there's going to be more follow-up. And it can be a little bit more of a roller coaster after cataract surgery compared to just cataract surgery alone. Yeah. So generally speaking, I think probably rules of thumb, you know, most MIGS, probably to some degree, slightly more follow-up, slightly longer recovery time. You know, that'd be safe to say.
We have lots of questions here about drops. So let me see if I can kind of condense those into a couple of questions. So there's someone here who's talking about their son who had infantile glaucoma and has been on some different drops and just wondering what the long-term effects might be of being on drops from someone so young into their adulthood.
Yeah, it's you know, it's tricky because I think the drops are they do have some side effects. Probably the biggest, fortunately, you know, generally speaking, they don't really have systemic, like, life-threatening side effects. You know, the rate of severe reactions is fortunately very low. However, they do irritate the ocular surface tissues. So like the conjunctiva, that's kind of like the skin of the eye, if you will. So that's the covering of the white of the eye. And there is reasonable evidence that those drops long-term, they kind of cause scarring, so that if one requires glaucoma surgery in the future, it's less successful. Not, you know, not doomed to fail, but just doesn't have as good a success rate compared to someone who has relatively drop naive ocular surface tissues. So I think that's probably that's why, you know, as glaucoma specialists, we it's tricky because a lot of our patients do need to be on multiple drops, but we try to be judicious. We don't just start everyone right off the hop on, you know, 4 different bottles. But we kind of take a tailored sort of stepwise approach to every patient.
So I have a couple questions about the interaction between the eye and the sinuses. So
Yeah.
for example, he's asking, does the sinus affect glaucoma? And then Glenn's saying, I have glaucoma and the drops cause sinus problems.
Yeah. So, you know, first, you know, we'll chat a bit about the anatomy. So our tears, you know, around our eyelids, they actually drain through the nasolacrimal duct into our nasal cavity. And it can actually, the glaucoma drops actually can affect our sinuses, our nasal cavity, even our throat. So a couple of things to reduce the systemic absorption or the absorption into the nasal cavity is that after taking the drops, close, you know, we get patients to close their eyes, you know, for 5 minutes. And we also, you know, get them to do punctal occlusion. So it's kind of pinching sort of the sides of the bridge of the nose. It's tough to demonstrate on Zoom, but that's definitely something to ask, you know, your eye health, your ophthalmologist about with respect to demonstrating punctal occlusion, because it's again, it's not a silver bullet, but that just keeps the medication around the eyes.
And so vice versa, if you have glaucoma, can it also affect the sinuses as well?
Yeah, potentially. You know, I not in everyone, but I think in some people it does have an effect there. You know, and I think what's another important thing for taking your glaucoma, or people taking glaucoma drops, to space them out about 5 minutes apart. Otherwise, the second drop will wash out the first drop if you take it immediately after. And it's we always tell our patients that, but it's definitely worthwhile mentioning.
So we have another question here from Marlene, and Marlene's asking, is an iridectomy still a good procedure for closed angle glaucoma?
Yeah, so iridectomy is basically iridectomy, technically that's when you're cutting out a piece of the iris in the operating room. We usually do an iridotomy, which is a laser procedure. That is mainly to prevent acute angle closure glaucoma. So, I mean, everything is sort of, it depends. Usually for patients who have legit defined angle closure glaucoma, so primary angle closure glaucoma, that is related to the natural lens of the eye being a bit too big for the eye, we are often moving towards lens extraction surgery. Now, it's not universal, and every patient is different, you know. I think the lens extraction surgery, that's basically cataract surgery, but the reason why we do it is not because, sorry, I just gotta log in. Yeah, sorry. So for lens extraction surgery, it's the exact same thing as cataract surgery, where we take out the natural crystalline lens and put in a thin, clear plastic lens, or IOL. It's called an intraocular lens, but we're doing it for a very different purpose. For cataract surgery, we're removing the natural lens because it's become cloudy and the patient can't see through the cloudy lens. In primary angle closure glaucoma, we're removing the natural lens because it's too big and it's blocking the drain and causing pressure or glaucoma issues. So it's a very similar surgery, but for two different reasons or two different indications. So I definitely, depending on the type of angle closure, and there's many different types, doing an iridotomy is still part of the treatment plan for kind of the most common form of angle closure glaucoma, which is primary angle closure glaucoma. Cataract surgery or lens extraction surgery is definitely becoming much more common because research has shown that it can be very effective and it does seem to be very safe.
While we're talking about procedures, Michael had a question asking if you could talk a little bit about the differences between MIGS and more traditional laser treatment.
Yeah, that's a really good question. It's becoming more blurred. So generally speaking, laser treatments were considered a separate category and less invasive than MIGS. And usually when we're discussing laser treatments, they're performed in clinic and not in the operating room. So they're technically not surgery, because we generally define surgery as cutting into the patient's eye and doing stuff. So, that's surgery. Usually laser, we don't have to do that, and laser, we previously haven't really done that. So probably the most common lasers patients would encounter would be something like SLT, selective laser trabeculoplasty. So that's an in-office procedure where it encourages the body's natural immune system to unclog the natural drain or the trabecular meshwork. So that's a nice way of thinking about it. So that's an in-office procedure that's kind of done within the same realm as when we do drops. Sometimes some doctors in certain patients do it before starting drops. Sometimes they tried them on drops and then see how it is and maybe switch to laser after. There are some, so those are lasers that unclog the drainage system. There are lasers that turn down the tap in the eye. So that's CPC, cyclophotocoagulation. And there's a newer version of that called micropulse CPC. That's still done in clinic, and it's technically not surgery because we're not cutting into the eye. That can, in some patients, that can lower the pressure quite a bit. In others, it's not as effective as surgery. So that's, so usually, generally speaking, laser is done before surgery. There are, however, there are some other surgical lasers that are actually done in the operating room at the time of cataract surgery. Some of them are relatively more experimental, but some others are more mainstream, like ECP, that's an endoscopic cyclophotocoagulation. It does two things. It turns down the tap in the eye partially to lower the pressure, but it also kind of pulls the iris down to make more space for the drainage system. So great questions.
So many different options for treatment, which is
yeah
to hear about. Yeah. Okay, let me take a couple of questions from email as well. So here's one from Laszlo is asking, is there any reliable research data that makes a connection between high anxiety levels and increased intraocular pressure readings?
Not Not directly. There is some case series and evidence showing that you know, mindfulness and meditation exercises can help actually reduce intraocular pressure. So I think there's probably something there to it in some patients, you know. So I know that that's, you know, not quite an answer, but I think there is evidence that reducing stress, you know, in our lives it's probably helpful for other things. And I do think it would be useful for glaucoma.
Here's another question about low pressure. So someone's asking, why is there vision loss due to glaucoma even though pressure of the eye is low? So what causes the vision loss when pressure is down?
Yeah, you know, and that's a great question. We don't know 100%, you know. So in glaucoma, we know the optic nerve gets damaged, you know, and dies off, for lack of a better term. There's different theories. And it's probably a combination of a bunch of different factors. So sometimes if there's a concept of optic nerve blood flow. So if there's not enough blood going to the optic nerve, it dies off. So usually what happens is in glaucoma, when there's high pressure, the high pressure in the eye is opposing the blood pressure or the blood flow into the nerve, so the nerve chokes off and dies. However, there's some people where, for whatever reason, they just naturally, like maybe they have cardiovascular disease, or maybe they have other factors where they have a very poor blood supply to the optic nerve to begin with. So even at a relatively normal or even a low pressure, that's not enough for the nerve to stay healthy, and it slowly accumulates glaucomatous damage. So that's, you know, that's one, you know, one possibility. The other reason we don't really understand is why some cells kind of start degenerating. So they are looking at different medications and therapies for what's called neuroprotection. So that would potentially be really helpful for people with true normal pressure glaucoma, where for whatever reason their optic nerves just start accumulating damage despite having really, really good pressures and good pressures all the time.
So I have a few more questions here about drops. So Judith is saying that she has had difficulty with drops, and she says that they're toxic to her, and she's really worried about maintaining her pressure with drops. Is there anything that she can do if drops aren't working for her?
Yeah, I think, you know, honestly, the definitely look at different laser options. And honestly, in some situations, we do, if drops and lasers aren't enough, we would consider surgery, like a micro-invasive glaucoma procedure to control pressure without using drops.
Another question, Dolores sent in an email asking, how common is it to have corneal damage resulting from several years of glaucoma medications? And she lists a few of those: Vyzulta, Cosopt, Alphagan.
Yeah, so I think that kind of is related to the ocular surface disease. So it actually, probably everyone has a little bit of ocular surface disease to some extent after being on glaucoma drops, and it does accumulate over time. So it gets worse with the number of years that a patient has been on drops, as well as the number of different classes they're on. One thing that potentially might help is switching to preservative-free versions of the drops. Not all glaucoma medications are available in a preservative-free format, but I think that, you know, that can be helpful. And if they're not necessarily available, then trying our best to optimize the ocular surface with preservative-free artificial tears can be really helpful too.
Another question here from Haiti asking, after glaucoma surgery, what does it mean if the doctor says that the surgery only lasts 5 years? Is this something that will maybe have to be repeated?
Yeah, so and that isn't, you know, guaranteed for everyone. It's sort of the probably let's say if you start off with 100 patients who have the exact same glaucoma surgery, after 1 year, a certain percentage of them will fail, meaning their pressure starts going up where you either have to restart drops or do additional surgery. So it's not guaranteed that every patient, every glaucoma surgery lasts about 5 years or so, but it's kind of just an estimate. So I think that's where I was getting with at that.
Is there any impact of intermittent fasting having a beneficial effect on low tension glaucoma or any form of glaucoma?
That's a really good question. I don't think there's any harm in it. I think if there's if we adopt healthy lifestyle, changes that kind of improve, improve like our blood pressure or cardiovascular health, then that's probably helpful. Probably eating lots of fruits and vegetables, like, joking aside, but transitioning to more of a plant-based diet potentially would be helpful. Like, I think making sure we get lots of, fruits and vegetables to get the, minerals, vitamins, and the antioxidants would be helpful. And in some people, dietary changes that reduce their overall inflammation in their body probably would be helpful too, so yeah.
And we had another question about exercise here, asking about swimming and running as activities. I wondered if the swimming too, in terms of like going underwater and like increased pressure, does that have any effect?
Yeah, so I think that should be fine. I think the main thing with I think probably the main thing with swimming and like water sports is if anyone has had blood forming surgery, so like a trabeculectomy or a tube or a Zen or a PreserFlow, they should definitely wear goggles or eye protection, because unfortunately those surgical sites, they can get infected if you open your eyes all the time underwater.
Okay, so we have another question here. So it says, as far as treatment staging, if pressures are increasing slightly or modestly with a drop per day, do you typically increase the number of drops per day, try different drugs, or move on to MIGS? And the second part of the question would be, does age of the patient impact the decision to have surgery?
Yeah, I think, generally how we escalate things, and every patient and every glaucoma surgeon is a bit different. It would be certain drops you can increase the dosing per day. Usually we add another class of medication, so a different bottle, or we use a combination bottle. Another reasonable thing would be to employ glaucoma laser if it hasn't been already. I think generally speaking, we kind of look at the full patient, to assess whether they're a surgical candidate. I think just because someone is older doesn't necessarily mean that they are not a surgical candidate. I mean, we've operated on the full spectrum, of ages when it comes to patients. I think it's more important sort of looking at what their comorbidities are, what other medications they're on, are they on any blood thinners, things like that. So
this is a really good question too. How often should individuals who are susceptible to developing glaucoma be monitored by their optometrist, including after they've had procedures that might minimize the risk, and then iridotomy, cataract removal, taking drops? And what are the most important things that should be monitored in considering additional treatments such as MIGS?
yeah, so I think, it depends on the severity of the patient's glaucoma, but generally, Canadian guidelines are that mild glaucoma patients probably should be seen every 6 months or so, and moderate to advanced every 3 to 4 months. So it varies from, so that's kind of like twice a year to around 3 or 4 times a year.
Great. And can you also talk a little bit about any research that's looking at the understanding possible benefits between glaucoma and vitamin D?
Yeah, I don't have that much experience in that research, so I'd have to look into that. So sorry, I don't, in terms of the vitamins, probably the other supplements that kind of have been looking most people have looked at is ginkgo biloba, because that's anti-inflammatory. So that's potentially promising. And the other one is mainly the nicotinamide. Those are kind of the forerunners. But again, glaucoma, it's a slowly progressive disease, thankfully for most people. So it really takes quite a number of years before we have answers for these questions.
Absolutely. So I'll just give everyone a last call for questions. We have a couple more here. So if you have any questions outstanding, feel free to pop those into the Q&A box. So can you talk a little bit about infantile glaucoma? We've talked about a couple different forms of glaucoma. So, if pressure stays stable, will glaucoma stay stable in the child, or is there potential for further vision loss down through into adulthood?
Yeah, it depends. For congenital glaucoma or glaucoma that presents early on in life, it really depends on the situation. There are some that are associated with syndromes, some that are just in isolation. For the ones that are just in isolation, generally surgery can be quite effective in controlling the pressure for a while. I think, unfortunately, there's always a risk of blindness with glaucoma, period. So, and unfortunately, any damage from glaucoma is permanent, and we only have a given, like currently, since we are looking, or not we, but people are looking at ocular nerve regeneration. So that's really, really exciting. But for now, we don't have that. So whatever optic nerve that we're born with, that's all we have, and it's a matter of making it last as long as possible. So in other words, it is more challenging for pediatric glaucoma because they are getting it very early in life, and we ideally want solution. Ideally, we'd want something that would last for 100 years, versus someone who develops glaucoma, in their 90s. We're not looking at the same time horizon. So I think there's always a risk for that. So I do think it's important to keep up with follow-up and monitoring. That being said, there have been quite a few success stories with primary congenital glaucoma with surgery. It can be very, very effective. So
I think we have time for one last question here. So how about this one here from Renew? And I think you mentioned a bit of this earlier, but maybe just remind us. So what is the success rate of MIGS, and how long has this intervention been in practice now?
Yeah, generally speaking, I mean, most of them are around 70% successful, and it depends on the specific device. The category of MIGS have been around for about 10 years or so, so it's a more recent advent.
That's great. Well, thank you so much for answering all of our questions, and thank you, audience, for sending in such great questions. That was we really put you through the ringer, Dr. Gooi. Lots of good questions today.
Awesome. Yeah, anytime. Thanks so much.